I'm Trent Summers.
And I'm Ryan. And joining us today is Dr. Christopher Spewock.
This is Hot Mic Chronicles.
Before we get started, a quick disclosure. Trent Summers is the founder and CEO of MedicForge. Ryan Page is the COO of MedicForge. Our guest today, Dr. Chris Spewock, serves as the Continuing Education Medical Director for MedicForge. Dr. Spewock has no other relevant financial relationships to disclose. This episode is for educational purposes, and the views expressed are our own and those of our guest.
So in today's episode, we are going to be talking to Christopher Spewock on what it is like to be a medical command doc, the thought processes behind the decisions that they make, how we as providers can do a better job of giving them a full story, what exactly they're looking for in a medical command report. That way you're not getting denied orders like I know that we all dislike hearing the no at the end of our command report. So, Ryan, you want to get us started?
Absolutely. So, Doctor, walk us through what goes on when you receive that phone call for a med command.
Well, so the med command phone has a particular ring. So when that phone goes off, one of the docs realizes that it's time to answer the phone, but it's always in the midst of whatever's going on in the emergency department already, and the usual things that we're dealing with, documenting and seeing patients, etc. So that phone goes off, and then one of us will get up and answer the phone, and then say, "This is so and so med command," and then it's up to you guys. You take it from there.
So pretty much at any given time, you already have 50 other tasks going on, and then all of a sudden we're just calling up to be like, hey, can we add one more on your plate real quick?
We need you.
Exactly.
So to you, what is a perfect med command call?
So a perfect med command call is one that is concise, but yet includes all the pertinent information and has a question, a specific question, and preferably all of that stuff. The pertinent information on the question is all said kind of in the first 30 seconds to minute of the call.
Yeah.
Ideally, when a provider calls in med command, if they can tell us in the first sentence or two what it is that they're calling about or what it is that they want, like for refusal or for medication for sedation, if they can lead with that prior to giving us the rest of the information, that's helpful because then it gives us some idea of what to expect.
Yeah, you and I have had this conversation before, and I've had this conversation with Ryan, that I personally don't ask for anything. When I call into Med Command, I give the pertinent information about my patient, and then I say, this is what I'm going to do. Do you have any other questions, and are you okay with that? Those are the two questions that I'll ask. But outside of that, I feel like someone that gives, unless you don't know what's going on, which we've all been there and we just need help, I feel like calling and saying, what do you want done? It leaves a bit of ambiguity as well as maybe a little bit of a lack of trust, because you might think we don't know what we're talking about or we don't know what we're doing if we're just asking you.
Yeah, I think that's fair. I mean, certainly when you call in and you know what it is that you want to do, and you're simply presenting it and kind of presenting it to us so that we can then approve it. That that inspires confidence in us that you know what you're doing and you know the reason that you're calling.
Yeah.
Yeah. So again, you said sometimes there are times when you call in and you're at a loss. That'll happen, but ideally you call in knowing what it is you're calling about and what you want to happen.
Well, and I think it's important also, if we're at a loss, you being on the other end of the phone, not being on scene, not being able to see the patient, you're also most likely at a loss.
And because you can only know what's being expressed to you, and sometimes it's not the entire story.
Yeah.
And it can be a little confusing to be like, sure, you should do this when you've only gotten that 45 to 60 seconds worth of a story,
Yeah, because then we end up backtracking and starting over from the beginning and asking sort of the initial questions that probably should have been answered in the first few sentences, which is like, well, where are you? Who's there? Why was there a 911 call in the first place? And then walk me through what it is you're dealing with. So because we're at a loss. We're only getting bits and pieces of information, kind of with no context.
Yeah, absolutely.
So when it comes to denying orders, what are some of the biggest factors that come when it comes time to make that decision on your end?
I think that I personally don't deny a lot of orders. I think I give providers a pretty free hand unless I think a request or a plan is just totally off the wall, which doesn't happen too often. But I know other providers are less likely to approve things, and I think that things that typically get denied are things which I guess can be done in the ER in 5 or 10 minutes and don't necessarily need to be done in the field. Like the thing that comes to mind is Cardizem.
I would say Cardizem is probably our number one most denied request.
Yeah, I think a lot of providers feel that it's something that can wait until the patient gets to the ER, and then the provider can assess them and provide that. Usually, diltiazem isn't given because somebody is unstable. Usually it's because we're just you're trying to kind of get a jump on things and get something done before they come to the ER. But some providers like to see the patient first. I don't have any problem with providers giving diltiazem in the field. It's one less thing that I have to do, and it is better for the patient if their heart rate can be controlled 10 minutes before they get to the ER. But I know that a lot of providers just prefer not to give that order.
Yeah, I think in my experience asking for that, the question always comes, well, how far away are you?
Right.
Yeah. And if it's anything less than 10 minutes, it's usually a no. But if it's over 10 minutes, most people are like, okay, sure.
That's why you're always 15 minutes away.
That's crazy.
I think other denials, if it's something that's not typically done in the ER and something we're not familiar with, there are some of your protocols that involve medications that we just don't often give in the ER. I think if the provider or if the doctor is unfamiliar with the medicine or doesn't give it typically, they may deny it just because you don't give it for that indication in the ER.
Right.
And that's just habit. That's not for any other reason.
Yeah, I know that one that is optional in Pennsylvania now that we at our full-time job that we give is droperidol. And I know that for our agency, you had wanted some literature and a little bit about why droperidol was being given. And that is one that has been denied before as an agency. We've had some people before, again, at our full-time job that have been denied for it.
I think that's also on them because it's not a med command drug.
Correct.
If you have an MCRAS score of at least 2, that is not a med command call, and you can give it for agitation. Where our other meds for agitation, you do need a med command consult.
Exactly. And that's something to me that, again, I'm not a med command doc. I'm just a paramedic. But at the end of the day, I do feel like sometimes when providers call for things that they don't need to, is that something that you're aware of as a med command doc with certain things? Obviously, you do your yearly updates and things like that throughout the state. But obviously, you can't be up to date on everything at all times. Is there ever a point where it's just trust with a provider? Or are there certain times where hey, like they didn't really have to call me for this. They're able to, but they didn't have to call me for this. And maybe that leads into your decision. Again, you don't really deny orders all the time, or much at all, but does that go into your thought process at all?
You mean the protocols and whether the protocols are being followed and whether... So I think that honestly, most of the med command docs aren't aware of many of the protocols, and certainly if there is a protocol that's new or has been recently updated, you should just expect that most of the docs aren't familiar with it. We should, we probably have access to it. I have an app on my phone that allows me to pull it up while I'm on the med command call to review it. That's helpful, but I think most providers, most of the med command docs don't have an intimate knowledge of those protocols, and that's so they're probably not refusing things because of the fact that it's not required. Like Repairol, for instance, in that instance, it's not required for you guys to call in there. They probably have no idea. To be honest.
Yeah, absolutely.
And so, again, I think it's if they're refusing it, it's either because they just think that it's not necessary or because they're not that familiar with it. Repairol is a good example. I mean, so I trained from 2011 to 2014. I think at that time, Repairol, the black box warning had just been removed. But during my residency, Repairol wasn't something that was used very often. So, docs that trained 10, 15 years ago weren't using Repairol for much of anything. It wasn't around. And so now that it's back around, I think that a lot of them are just getting used to its, availabilities.
Yeah. I mean, when we first got Repairol, my partner and I brought in a patient that we gave Repairol to after being denied orders for Versed. I wasn't super happy about that one, but I was like, well, per our protocol, we were allowed to do that. And there's only one way to get this patient in here, so.
You denied Versed, not sedation.
So how much does personal rapport and inflection on the phone dictate how that med command call goes?
I think that goes a long way. If the doc knows the provider calling in, if they already have a relationship with them, if they realize that they know what they're doing because they've been working with them for some period of time, then I think that docs give them a lot more leeway. And so, to the extent that EMS services can hang on to providers and keep them happy and keep them on board for a number of years, and those providers then can, develop and maintain a relationship with the local ER doctors, that's a plus. And then there's just a lot more trust and a lot more leeway given on these med command calls. And when somebody calls in and you have no idea who they are, it just makes it harder to trust that they know what they're doing because you don't know who they are. It does help if then when they call, even if you don't recognize them, that they give a presentation that is concise and to the point and demonstrates to the doc that the person on the other end knows what it is they're talking about, what it is that they're doing, and what it is that they want. That helps to build trust right away. But that goes back to our initial point about what makes a good med command call.
Yeah, absolutely. And for the audience, as Dr. Spewock has mentioned, I think this is where it's really important when you bring these patients in that you are going back to the desk, as long as they're not super busy, that you're going back to the desk, talking to the doctor, as well as giving a report to your nurse, but talking to the doctor, building that relationship, letting them know your thought process behind calling them, behind your field impression, behind your treatment modality, and what exactly it is you're doing for your patients, because they don't know what's going on in your brain. They only know what you're telling them. And while it may be out of the realm, you may have had great intentions on your treatment modality, but you just need to explain that to them. And that's something that I know myself and Ryan personally do with doctors at our local hospital. We will go back, talk to them, and let them know exactly what it is that we were thinking and what we were doing. But I think it's super important for you guys to understand that and go through with that.
Yeah, absolutely.
Yeah, I think that goes a long way. When a provider comes after the call is done and the patient's been handed off and everything's kind of settled down, and they come over to us and say, how did that go? How could I have done better? What did you think of that? Can you tell me more about either didn't approve or approved, or why you recommended this, that indicates to us that you care about learning more, that you care about the patients, that you want to get to know us, and that you appreciate our opinions, and also it just helps us to get to know you guys.
Yeah.
So I think that's a great bit of advice, and I would recommend that everyone do that.
Yeah, absolutely. What's everything that we're going to talk about today is a little bit deeper of a dive into each question, but what's your 1,000-foot view as a med command doc when you hear that phone ring? What's going through your head when someone on the other line says, hey, I have a 50-year-old female, chief complaint is this, they end? What's your 1,000-foot view as a doc that we don't necessarily see?
Well, we're always thinking about the fact that this patient is, assuming it's not a refusal or asking us to, terminate attempted resuscitation, we're thinking, okay, this is a patient that is coming to us in the very near future. And so we are already thinking about what we're going to encounter when the patient comes in the door, and what our plan is going to be, and what we're going to have to do. So that, I think, is sort of the broader scope for any ER doctor. They're thinking about what they're going to see and how they're going to deal with it.
Mm-hmm.
And so any question that we ask, anything that we recommend, it is ultimately with an eye to how we're going to be managing the situation in 10 minutes, 30 minutes, whatever the case may be. So that, I think that's something that might be helpful for EMS providers to keep in mind, is that you're obviously dealing with it firsthand. You're the first responders. You're sort of sorting out the mess. But then once you get on the phone with us, recognize that what we want to know is everything that we are thinking about is in terms of how we're going to deal with it, obviously, because then it's just our situation.
Yep.
Yeah. Well, I think it's interesting that most of our BLS level providers really don't have too much interaction with the docs on, even for med command calls. For the BLS level, there's really not a whole lot of boxes that say, hey, I need to call, other than maybe tachycardia, a weird blood pressure. But other than that, they're not calling for orders. Mm-hmm. If they're bringing a BLS patient, there's sometimes where doc doesn't come into the room until after they're already gone. So I think there's not really a chance for them to have that interaction like we do as ALS providers, where there's a whole lot more conversation to be had.
Yeah.
So it kind of stunts that relationship until they get to a certain level. Mm-hmm. So it's just kind of interesting to see that.
Yeah, but I think that's something that the audience can do, mm-hmm. is introduce themselves.
Oh, absolutely.
They can take time. Again, this field is what you put into it, you're going to get out of it. And I think taking that time to talk to docs, I think taking that time to, even the nurses, taking time to talk to them, what do you see that I didn't see, and things like that would benefit the audience so much. Mm-hmm. Is just spend that little extra time. It's not always about getting back to your station right away. It's not, going to get your food, although I know that we're all super hungry all the time because we don't get to eat. But taking that time to talk to the nurses, talk to the docs, and see what exactly they're seeing that maybe we didn't see. Having an extra eye is always important. Absolutely.
Yeah, and when you introduce yourself, say your name. That goes a long way, because it just helps us to remember who you are. And honestly, most people, even when they come up and start talking to us, they don't just introduce themselves and tell us their names. I have their badges there, but it helps if you say your name. And I think also it helps if you have a professional attitude.
Yeah.
If you come in and demonstrate some professionalism, I know there's a lot of black humor in the field and in the ER. That's just part of how we get by in this field. But But demonstrating professionalism goes a long way. And when you come back in with that next call, or when you call in on Med Command and we recognize your name, and you've already demonstrated professionalism before, not that I'm speaking not just for me, but also for nursing, we are much more likely to take what you have to say seriously, because it demonstrates to us that you care about what it is that you're doing.
And I think that's super important. You and I have a personal relationship as well as a professional relationship, but how I talk to you on the radio isn't how I would just walk up to you, whether you're at my house or I'm at your house or we're at a restaurant or what have you. It's very much, hey, this is what I have, this is who I have, this is what's going on. And I feel like that's huge for the audience to understand exactly what you just said. Yeah. So while we're talking about being a Med Command doc, what is it that got you into emergency medicine in general?
Well, so for me, medicine was sort of like a second career. I studied history as an undergraduate, and I sort of I went into academics briefly and started a PhD program, and then was working in marketing, and then I made my way into medicine sort of in my late 20s.
Okay.
But at that time, I started volunteering in the ER at Pennsylvania Hospital, which is in Center City, Philly. And so right off the bat, I realized that I liked the emergency department. I liked the energy. I liked being able to do procedures. All that appealed to me. And then the shift work at the time appealed to me. Not being on call specifically. To me. As I get older, shift work is less appealing, but it is nice to not be on call. So these are the things that I was thinking about at the time, and so when I went to med school, I already had in mind that I knew I liked the emergency department, and unless I found something else that I fell in love with, that I would like to just go into emergency medicine. So that's what happened, and I started residency in 2011, so 15 years ago.
Yeah. So going off of you're this emergency physician, and maybe not necessarily always what you wanted to do, but you found your lane. We had talked previously about stuff rolling downhill, and how when we talk about us getting yelled at by ER staff, do you ever get yelled at by other doctors, whether it be internal medicine, cardiology, ortho, or anything like that?
Well, so fortunately where I work, no one, everyone's very collegial. Everyone's very...
Right. Maybe not yelling.
But yeah, you get second guessed by people further along in patient's care. Yeah. So when the patient gets admitted, and then the hospitalists have had some time to narrow down the differential and get a better idea of what's actually wrong with the patient. When they look back at what we thought might have been the problem in the ER, they will sometimes second guess our opinions, and specialists as well will second guess our opinions and make comments that maybe we're a little foolish or stupid for thinking that the patient had a COPD exacerbation when really they were in heart failure. But
right.
And so we take that personally because we don't have all the information at the time the patient walks in the door. We have a broad differential, and we haven't eliminated all the possibilities. That said, we often do the same thing to first responders, to EMS providers. You guys have even less information than we have. You're on the scene before we are, so you make decisions and you have suppositions which are based on what's available to you. And it's easy for us who have a little bit more information to then look back and make snarky comments or laugh. But
Once you have labs and everything.
Yeah, and and if you guys miss an airway in the field, and then we get an airway in a much more controlled environment, it's so much better. But the reality is that it's a different environment and it's much more controlled. So
yeah,
well, that's important because I know some providers do kind of like take that as like almost like a confidence hit when they get yelled at for whatever have you, even though it's not supposed to be personal. Sometimes they take it personally as like, man, I'm just a dumbass. I messed up. I should have known that. And that's not what it's meant to necessarily be, but sometimes that's how it can get taken. But it happens to everybody, no matter how far up the food chain you are. Everyone's getting it from somebody else.
Right. But I mean, a good doctor speaking to an EMS provider will be trying to educate them rather than trying to just denigrate them.
Yeah, absolutely. So we've talked a bit about what it's like on the other end of the line, but we've also mentioned after the call, after transfer of care has happened. But what about transfer of care? I know that you're one of the docs locally that will come into the room and hear an EMS report. What are you looking for in those moments? Is it the same as the pre-arrival call?
Yeah, I mean, it's very similar to the pre-arrival call, and I liken it to the way that a resident in a teaching hospital will make a presentation to an attending. We basically want to hear the same sort of presentation from that resident as we would want to hear from a paramedic making a presentation in the room. And that is something, again, which is concise and pertinent. So you're, for example, you're saying a 70-year-old woman with a history of, and then you list just the relevant history. I mean, if the call was for chest pain, you want to say history of coronary disease and COPD, who called for chest pain, and then to walk us through just what happened, but what happened that was relevant again. So we arrived. She was sitting on her couch. She was obvious respiratory distress. She was hypoxic on room air, but 70%. And then tell us, if she's hypoxic on room air at 70%, well, does she normally wear supplemental oxygen or not? If she's supposed to be on 6 liters and she was on room air, well, then let us know. Oh, but she's supposed to be on 6 liters. And then we put on 6 liters and she was 98%. All these kind of information is useful. But it really just comes down to telling a good story, including the relevant information, pertinent information, and doing it as concisely as possible. If you can do that, any good doc will be happy. It'll help us so much because you've just done half of our job for us, and if you're somebody that we trust and we know the information is reliable because you're a good provider, then we can just kind of dive into the next steps, and we don't have to go back and get all that information again. We can sort of move on with stabilizing the patient, ordering labs, getting the appropriate imaging, ordering whatever additional tests we need to order, getting ready to do whatever procedures we need to do.
Right now. On the medical command side of things, Ryan, do you have anything else you want to know?
I mean, we've hit a whole bunch of major topics today that
useful.
Yeah, absolutely.
Do you mind, Dr. Spewock, if we go off script a little bit and maybe talk about a couple medications that providers would need to call for, and the use of them and how you feel about them, and keeping it basic things?
Yeah, I mean, I'll just speak to my own personal preferences. But
something that I know that we need to call for in Pennsylvania is magnesium in breathing patients, in our breathers, and it's something that I personally find will turn a patient around in no time. Is that something that you use in your treatments in the ER? And is it something that you think maybe is underutilized in EMS?
I don't know that it's underutilized. Maybe it is. I do get calls from time to time asking me about that. I don't think I've ever said no to magnesium. I know that it's something that's been used. for a long time.
Yeah.
This is not new. There's a lot of evidence for it cited back when I was a resident 15 years ago, and that evidence wasn't even that new at that time. So, I don't think it's a controversial, medication to give. I think that there's evidence that it's useful, and I don't see much harm in giving it. So whenever I'm asked for it by somebody in the field on a med command call, I always say sure, absolutely.
Yeah, absolutely. Maybe getting a little more controversial in medications. One that I personally know that paramedics are denied, and maybe they, again, previous to this episode, maybe they aren't giving the proper report or something like that, as well as some legal ramifications that we have seen as medical professionals. What's your thoughts on ketamine and the use of it in agitated delirium or something of that nature?
Well, an agitated delirium, it's very useful, and it's something that, I came from Philly before coming out here to Gettysburg, and it's something that was used pretty commonly for agitated patients in Philly. So it's something that I'm very familiar with, and have you had a lot of pushback on from providers or from docs when you wanted to use it in the field for?
I don't want to be that guy. I personally have not. There have been times that I've been denied orders, not for ketamine specifically, but I know through, again, at our full-time job, our QA/QI process, there have been denials for ketamine before, as well as just hearing stories in general.
I think it's also, the line's kind of blurred when it comes to agitated patients or anything of that sort, because depending on how agitated we're talking, you can administer prior to calling if it needs to happen, but you have to be able to explain why you weren't able to call first for it, and then be able to back it up with, I had to do this or else things were not going to go well. And it has to be very specific. So I think that makes it the line is just gray of, how mad is too mad before I can just give it without calling.
Right.
Which is why droperidol is extra nice, because that it's real low budget. It's, just really not, working with you, refusing vitals, stuff like that, agitation. Mm-hmm. But, when it comes to Versed or ketamine, they have to be much more aggressive for that to be your above the line call.
Yeah. Agreed.
Yeah. Are there other meds that you find that you want to use in the field and that you need med command for that are denied?
We brought it up earlier. Diltiazem is, I would say, probably our most denied out of all of them. I get it, especially when we're talking about distance to the hospital and wanting to just kind of get the full picture. So I know I had one a few weeks ago that I thought was SVT, and based off of my 3 and 12 lead, it looked like SVT. Mm-hmm. I had two pauses with 2 rounds of adenosine. Didn't necessarily break, but came down to about 150. Mm-hmm. I forget who the doc was. Said it was a flutter. Mm-hmm. They gave Cardizem, and ended up having to give Epi and Benadryl because the patient had an allergic reaction to Diltiazem. So I was like, glad I didn't give that. Good thing that wasn't me.
Yeah.
Have you ever been denied orders, Ryan?
Yes.
What for?
Diltiazem. Yep.
Is that about your only thing?
That's the only one I regularly might get denied for. Everything else, the Versed that one time that we gave droperidol instead, but
yeah,
I think that was because my partner didn't, like we talked about, he didn't paint a good picture. Mm-hmm. This patient needed to be sedated or else they were not coming, and PD said, we're not going to do anything. Mm-hmm. Okay, well, I'm not trying to get hit in the face, and his patient sugar is 600.
So actually, that's something that, these sorts of scenes where there's an agitated patient, we have a hard time, I think, as doctors on the med command line, understanding really what the situation looks like. Mm-hmm. So the more that you can describe that to us, the better, better off everyone will be. But for instance, when you're at a scene where the patient's agitated and the police department or police officers are there, what is typical? Like, are they just kind of like hanging back and letting you guys do all the work, or are they stepping in? Like,
typically, they'll wait until they have to do something. If this, because they're in their minds, this is a medical emergency, and their need is just to be there as a keeper of the peace. If they, grab something and start throwing stuff, then they can intervene. But other than that, they really won't.
Yeah, and that's something that the Bureau of EMS in Pennsylvania, as well as our local council, is really trying to go after, is talking to these police departments, talking to the officers, getting their rationale for not wanting to step in. Because something that I've never ran into this with you, but there have been instances where providers have called in, the patient wants to refuse, but the med command doc does not believe that it's within the patient's best interest to refuse. So they say, well, you need to bring the patient to me. And the patient is violently refusing. The police department doesn't see this as something that they can deal with, because even if the patient is alert and oriented times 4, what legally have they done wrong?
Right.
So this is where the police department says, well, that's not our job. We're here right now, but we're not willing to go hands-on with this person, because they do have rights as human beings. But this is something that is developing within the Commonwealth, and I'm interested to see where it goes.
So, like, an instance I could imagine, like a scenario would be someone who's intoxicated, has fallen, and has obvious injuries, like head injuries, for instance.
Yeah.
But doesn't want to come in to be evaluated. For whatever reason, you're there because maybe they called or somebody else called, and now you're asking us if they can refuse. They're intoxicated, obviously intoxicated. So we would say, well, they don't have the capacity to refuse care because they're drunk. But whatever the case may be, would that be a case where the police would say, well, we're not in a position where we can't drag this person in because they haven't broken the law. They're drunk in their own home, they've fallen, they don't. Would that be like an example?
Yeah, that would be an example.
And then it's, how do we now wrangle them and force them to go when they're already agitated?
Do we sedate them? And it gets to this, EMS professionals are told from the very beginning of their career in school, patients have rights, which is very much true and a great thing. But you have to be careful of certain things. And I think that we get hung up on the legality of things not too much, but we get hung up on the legality of things because we sit there and say, okay, well, if this happens, what happens to me? What happens to my certification? What happens to my license? What happens? And I think sometimes can get in the way of what's in the best interest of the patient. And that's a really hard call to make, especially when you have someone on the other end of the line that has more education than us, and isn't there right now. So they want the legal CYA of, I saw this patient. I think it can become a bit convoluted sometimes of what happens next. True. Yeah. So do you have anything else for Dr. Spewock, Ryan?
I think we've covered a good amount of topics tonight, and should open up some new areas of information for some people that might not have known or might not have even thought about it before.
Yeah, absolutely. Do you have anything else, Dr. Spewock?
No, thanks for having me, guys.
Yeah, absolutely. So I think for tonight, we have covered you as a provider need to be diligent in your reports, need to be concise in your reports. I'd imagine by concise, you don't want a 5-minute dissertation about a patient.
No, concise is more like a minute.
No.
Ideally.
Yeah.
Yes.
As well as be educated in your treatment modality when you are explaining it to a medical command physician. They are not there with you. They don't know exactly what's going on. They're only hearing what you give them. So at the end of the day, we can't get upset when we're denied something because it's probably on our presentation, or maybe they have that 1,000-foot view that we're not necessarily thinking about. So going forward, we are going to Texas, and we are going to have a very special guest for Texas. But right now, if you're following us on YouTube, please like, comment, subscribe. It helps us with the algorithm, helps get this out to more people. If you want continuing education for this, you can go to medicforge.net/CE, sign up for a free account. You can subscribe on there for $69 a month.
Nice.
And you can receive continuing education for all of our episodes that we do, although there are some on there that are free. But for tonight, that's all I got.
Yeah. Doctor?
Guys,
Thank you.
Yeah, thank you so much.
Yeah. Have a great night.
See you next time.